Pericarditis is an inflammatory pericardial syndrome that presents with or without a pericardial effusion. The diagnosis involves clinical criteria based on two of the following: pericardial chest pain, pericardial rub, ECG criteria, and the presence of a pericardial effusion. The ECG findings are unfortunately not always present, and they're estimated to occur in approximately 60% of cases. It's suspected that the ECG changes in pericarditis are due to the inflammation of the superficial myocardium, or alternatively, due to fluid, for example, if there was the presence of an effusion. The first finding is diffuse concave ST segment elevation, often occurring in all leads with the exception of AVR and often V1. The extent of the ST elevation is generally modest, but it is widespread. So the total surface area involved is generally going to be more extensive in pericarditis than for an MI, but the degree or the depth of the muscle involvement is less, it's smaller. So less significant ST elevation, but generally seen across a wider number of leads. Here you can see also significant PR depression, which is another key feature in pericarditis, and you can see the Coved ST elevation. You can often see a mirror image in AVR with PR segment elevation. Interestingly, like for a myocardial infarction, the pericarditis ECG patterns show an evolving picture, and this occurs on a scale much slower than for an MI, which can be an important differentiating factor between the two. So the first stage in pericarditis involves the diffuse concave ST segment elevation with PR depression. This evolves into a second stage where the ST segments return to the isoelectric line with flattening of the T waves. The third stage involves the diffuse inversion of the T waves, and in stage 4, generally they either normalize or in some cases there can be persistence of T-wave inversion. The main differentials are those of STEMI, an early repolarization pattern. Here is an inferior STEMI, and you'll notice that the ST elevation is very significant, pointing more towards STEMI than pericarditis, and also it's greater in lead 3 than lead 2, pointing more towards STEMI than, say, pericarditis or early repolarization pattern. Alternatively, we also have a convex pattern of ST elevation rather than a concave, and that again is more consistent with STEMI. Some features are important in their absence when we're looking at making a diagnosis of pericarditis, especially there shouldn't be Q waves, or there shouldn't typically be Q waves in pericarditis. Reciprocal changes are another important negative. If present, they should be confined to AVR and V1.